I want to welcome our presenters, Joan Kagema, our respiratory nurse, and James Moyai, our respiratory clinician. And we will begin with presentation by Joan Kagema. I'll be your moderator. I am Gladys Cheruto, respiratory clinician. You're welcome.
Thank you. Good afternoon, and thank you. Can you see my slides? Are you able to see my slides?
Yes, we are seeing Joan.
You can see them, eh? Okay.
Okay.
Good afternoon. I want just to do about asthma education, as is the theme of this year of 2024. So at my background, there's asthma education that empowers. That is the theme of 2024. So my objectives today, this afternoon, is to identify the characteristics and the symptoms of asthma, tools for assessing asthma, recognizing asthma triggers and control strategies, explain asthma medicines and devices, understand the value and the use of asthma control test, ACT, and asthma action plan, AAP, and also how to respond to a breathing emergency. It cannot go, sorry. So I've just did, I want to give about definition of asthma. It's a chronic inflammatory lung disease, cough, wheeze, dyspnea, and chest tightness, airway narrowing that is partially or completely reversible, increased airway responsiveness to stimuli. We come to asthma pathophysiology overview. We can see a normal lung, which has a bigger airway, and you have the asthmatic lung, which the airway is just swollen and also narrowed, and you can see the difference. So when you talk about the pathophysiology, you talk about inflammation, narrowed airways, constricted muscles, airway hyperreactivity, and rebonded airway. The causes of asthma, there are three things that make it hard to breathe: swelling inside the airways, tightening of the muscles surrounding the airway, and increase in mucus. What are the symptoms of asthma? One of them is coughing, often worse at night, fast breathing and chest tightness, noisy breathing, which we call wheeze, and the chest caving in, which we talk about retractions. Other early warning signs, they are scratchy, itchy throat, tummy aches, throwing up, running nose and sneezing, red and watery eyes, dark circles under the eyes, especially in children, feels tired, quiet, and is aloud. There is always a change in behavior. You can't sleep, and there is the decreased appetite. When you come to how to assess asthma, there are tools for assessing asthma. We include the peak flow, which we use a peak flow meter. We do the spirometry or the lung function test. We do the clinical symptoms by issue of the history and also inquiring about the allergy. We do about the blood test. We also do about the asthma control test, where you assess the patient what problems have been going through during the time, either cough, whether wheeze, whether he is not able to wake up, how many times that he has been. That is what we call about asthma control test. We can also do a FeNO, a fractional exhaled nitrous oxide. We can also do oscillometry, which is the newest diagnostic machine. We can also do skin allergy test. So diagnosis when we are using a peak flow meter. You can see a peak flow meter and how you can do it. So peak expiratory flow measurement is a simple measure of the maximum flow rate that can be achieved during forceful expiration, following full inspiration, more variable and effort dependent, uses predicted peak expiratory flow reference values. Peak flow meter is used in diagnosis and monitoring of asthma. When you are doing spirometry, the National Asthma Education and Prevention Program recommends spirometry to be performed in patients older than 5 years. So in children, we can also do, and actually we do the children's from 5 years and above. When the FEV1 is less than 80% predicted, FEV, forced expiratory flow rate of 25 to 75% less than 65, correlated with the reversibility airflow obstruction in children with normal FEV1. Before and after bronchodilator, where there is an increase of 12%, maybe 9% in children. Normal spirometry or the lack of reversibility does not exclude the diagnosis of asthma. Those are the spirometry curves that will always show us the loops. We show us how the client has taken in air and blown out when he has inspirated and also expirated. In that spirometer, you can be able to take a peak flow rate of that patient, and you can also be able to take a volume. Like in my right side, the loop shows like there is an obstructive because it goes up high and then it turns back inside like it has a curve. When you are doing oscillometry as a diagnosis, it's a test measures blockages. It measures blockages to airflow in lungs, and it is used to check lung function or pulmonary function in very young children or other people who have difficulty following directions or breathing deeply. It evaluates resistant pre and post bronchodilator and also requires passive cooperation. At the moment, we don't have oscillometry in Kenyatta, but in some other facilities, like in Aga Khan, they may be having an oscillometry machine. Other diagnostic modalities are bronchoprovocation testing. It's a test performed to evaluate how reactive or responsive of the lungs. We also do allergy testing, limited to seasons and suspected exposures, where you want to know whether somebody is reacted to something, like when you have you want to check about whether somebody is reacting to food allergies or to pollen or to any other exposures. We also do exhaled nitric oxide, which shows the levels elevated in patients with asthma or chronic exposure to passive smoking, and may forcefully decrease the levels. Then we come to common triggers. Infection linked to influenza or flu. There is colds and respiratory syncytial virus or RSV, sinus infection, acid reflux, and allergies. Other triggers is pollen, physical exercises, weather, which includes bad weather, such as thunderstorms or high humidity, breathing in cold or dry air. The other triggers is strong emotions, like those ones who get angry and they get an asthmatic attack, or those who can become excited. And this can lead to a very fast breathing called hyperventilation that can also cause an asthmatic attack. Common asthma triggers, they are tobacco smoke, dust mites, outdoor air pollution, pests, e.g. like cockroaches and mice. There can be pets, like the cats and the dogs that we keep, or the chicken. There can be molds, food allergies, and strong smells. And how to deal with the triggers is to avoid them, keep the environment free of the things that cause trigger in asthma symptoms, limit exposure. If suddenly faced with the trigger, move away from it. Take action by taking medication regularly to avoid a trigger. And you can always have an yearly flu vaccine to reduce flu symptoms. We come to asthma medicine. Asthma can be well controlled with the right medicine. Asthma medicines are safe and work well when taken correctly. The medicines are not addictive, and hence children or anyone using will not become dependent on them. There are two main asthma medications: rescue medicine or quick relief medicine, short-acting beta-2 agonist, bronchodilators, which is a quick relief. There's the long-acting beta-2 agonist, bronchodilators, and there is long-acting muscarinic antagonist, which we call them LAMA. Reliever medicine or short-acting beta-2 agonists, these are drugs that act quickly within 5 to 15 minutes and are effective for 3 to 5 hours. They are given for the immediate relief of breathlessness. An MDI or an inhaler is a device that contains asthma medicine. It delivers the medicine into the lungs. The MDI needs to be used in a certain way or it may not work. They come in inhaler form and also can be used with a spacer and a mask. Controller medicine or inhaled corticosteroid controls the swelling of the airways. Swelling is the silent part of the asthma which can be dangerous and cause death. This medicine has to be taken consistently every day and can reduce and prevent swelling of airway, but does not relieve sudden symptoms of coughing, wheezing, or shortness of breath. The combination medications like rubber, they contains inhaled corticosteroid and long-acting beta-2 agonist, the LAMA. The preventer medicine keeps down inflammation in the airways. The long-acting bronchodilator medicine gives ongoing relief from symptoms such as breathlessness and a tight chest. Combination inhalers come as either an aerosol or a dry powder inhalers. And some examples of combination inhalers are the Seretide, the Symbicort, the Formalin, and many others in the market. There are combination inhalers. There are also some combination of inhalers which are suitable for children too, because asthma affects both adults and children. So we need to know about the MDI and the spacer. In Leo sense, the spacers are not only for children, they can also be used by the adults. Children below 5 years can use a spacer and a mask. For those currently with no respiratory effort can use spacer and a mask, e.g. like the disabled, the very elderly, and those who cannot coordinate. The use of these devices helps delivering of the medicine in the lungs. And note, it can improvise. In case you don't have a spacer, you can also improvise with the use of water bottles when they are dry. So when we come to the asthma, we need to know about the asthma control test. It is a test to assess how well kinds of asthma are controlled. ACT assesses the frequency of shortness of breath and general asthma symptoms, and the use of rescue medications, the effect of asthma on daily functioning, and overall self-assessment of asthma control. So there is a chart there that is showing about how to assess yourself and how you can assess a client depending on for how long has he been having those symptoms, and you'll be able to manage that patient well. The higher the score, the better the asthma control. If the score is 19 or less, then asthma may not be controlled as well as it could be. So if you are below 19, after the scoring yourself, then you can realize that you are not well controlled, and you need to go back to the drawing board and understand and know where should you improve, especially in terms of use of inhalers, because most of the time that is where the problem is. There's also the asthma action plan. When you have somebody who has a very severe asthma, you need to have an action plan so that you can be able to manage that patient, and especially in children. Everyone with an asthma should have an asthma action plan in writing. The asthma action plan provides an information and instruction on how one can manage asthma. It includes the medicine. It recognizes when the symptoms get worse and what to do in case of an emergency. Asthma action plan also helps the schools and other caregivers about child's asthma, especially when the children go to school and sometimes they get an attacks or they are coughing. At least when you have an action plan, you are able even to tell the teachers to assist you in giving the child the spacer with an inhaler and what he can do in terms the child gets an attack. How to respond to a breathing emergency in case of emergency or attack at home. Ensure you have a spacer and a mask and an inhaler. You can give up to 10 puffs through the spacer at every 30 to 60 seconds. It should be given in one puff. It should be given one puff, 10 breaths till the patient is able to breathe, and so that they can go to the emergency room. Use of MAT or maintenance and reliever therapy is a combined inhaler that is used to relieve symptoms. When you have that one, you are able to take care of your asthma even in times of emergency. There are 6 steps to take to keep asthma under control. 1, making medical visits more productive. So especially as we are health workers, you should always encourage our clients to do frequent visits, which are more productive, asking the right questions about asthma management and treatment. The next time the client sees the healthcare provider, so that because this year is about education and information. If the caregiver is well informed and has education, you'll be able to facilitate. You'll be able to give the information, the right information, to the clients that they shall be able to benefit. Step 2 is to create an asthma action plan. Develop a plan with the patient that includes key information on managing their asthma. 1. In such a case, in a patient who is doing an action plan, you need to know whether the drug that is using is right for her age, whether he is using rightly, whether the device is correctly being used, all those that comes with the asthma action plan. Assess and monitor the asthma control. That means that you can have a peak flow meter. The patient can have a peak flow meter. That way the diabetes have the glucometer to assess their blood sugars. If a patient is able to afford a peak flow meter, then one is able to monitor and to track the symptoms each day and can help to know whether the asthma is under control. Understand the asthma medication. Most of the times we have disparities in terms of asthma medication. So you need to understand the asthma medication. If it is an MDI, how do you use an MDI? If it is a turbohaler, how do you use a turbohaler? If it is a discus, how do you use a discus? When should you use that medication? Should that be twice a day? Should that be PLN? Although these days we don't use salbutamol or as a rescue medicine for adults and also the teenagers or the adolescents. Learn the types of asthma medicine and how they work. So that is where the asthma medication comes in. The step 5, you need to reduce the asthma triggers. Know what causes the asthma symptoms to start with, and how this can be, and how the triggers can be sorted out, and they vary from one person to another one. Especially, there are people who react to perfumes. There are others who don't react to perfume. There are others who react to smoke. Others react to strong disinfectants. Others react to many other things. So step 6 is asthma self-management skill. Learn more about asthma, including the asthma basic course, update and understand the latest guidelines. The take-home message: all patients should receive asthma action plan, initial assessment of asthma severity, review of asthma level of control at follow-up visits at least every 6 months, assessment of exposure to allergens and triggers, asthma education by a qualified health professional, refer to an asthma specialist when appropriate, education regarding dangers of overuse of beta agonist, information regarding risk factors for death of asthma, and also good inhaler technique. My references are GINA guidelines, Kenya National Asthma Guideline, National Asthma Education Program, ATS and ELS guidelines. Any questions? Thank you.
Thank you so much, John. That was a very elaborative presentation. Thank you so much. We will go to our next presenter, who is James Moyae, but let your questions come as note them down. Some we will answer them on the type, and others we will respond after our next presentation. Welcome, Dr. James Moyai.
Okay, thank you very much, and welcome all again for this webinar. Indeed, my colleague has done a very elaborate discussion about asthma, and my work is just to give a short overview about prevention of asthma, strategies that we need to have to prevent asthma. So it will be a very short presentation, and much of what has been discussed, we'll just go over it very in brief. So, understanding asthma triggers, we have been told, she has talked about the common asthma triggers, which include pollen, dust mites, smoke, pollutants. So it is important to have the avoidance of these triggers so that we prevent asthmatic symptoms. So the most important thing we need to tell our patient is to ask them to make sure that the indoor environment or air is clean, and we can use air purifiers, the high effective filters. They look like the filters that are used in vehicles to filter air that gets into the chambers. So some of them can be used to purify the indoors, or rather the rooms. Then we have regular vacuuming and dusting, such that we don't have dust being blown out in the house, as that is one of the common triggers for our patients. So we need to have our beddings washed regularly in hot water, and preferably weekly. So we need to have also maintenance of optimum humidity levels to prevent growth of microorganisms, especially fungi. So the other factor that we need to emphasize in the prevention of asthma is the cessation of smoking, as well as avoiding secondary smoking. And secondary smoking is where we have somebody in the room smoking, then the rest of us in the room would also be equally passively smoking. So it is important to quit smoking, because smoking smoke alone has a lot of chemicals that really cause irritation to our lungs. So we also need to monitor our air quality, and we need to stay informed about outdoor air quality. Sometimes we have a lot of pollution in the air, and when we know we stay in environments where air pollution is a great risk, we need to stay away from it as much as possible. So there's use of air conditioning in high pollen days. Okay, so when we have a lot of pollen, then in the room or outside we can use air conditioning. So we need to limit outdoor activities during high pollination levels or pollution levels. So when, for instance, there is a factory that is emitting a lot of chemicals, then you can stay indoors to be able to avoid inhaling a lot of that of those chemicals. So we need to develop for our patients an asthma action plan, which my colleague Kagema has really elaborated it very well. that healthcare providers, we need to partner with our clients so that we're able to come up with a document that will include, among others, a document that will have the particulars of the patient, the medication the patient is using, and the triggers that the patient has. So steps. So there, as she said, there are steps to be taken when asthma symptoms are or have worsened. And we say there's the use of rescue inhalers and medications adjustments. So this is when the patient has worsened. We normally step up on the medication so that we are able to take care of that acute exacerbation. So we have the other preventive measure is to have regular exercise. When you exercise, you literally ensure that your lungs is also functioning optimally. And exercise is important because you're able to improve on the lung functions. Then there is the issue of exercise precaution, especially when it is very cold and very dry, because these are triggers that sometimes can cause an attack or exacerbations. Stress management. So impact of stress on asthma symptoms. So when you're severely under stress, then that is known to cause asthma. And therefore, it is important to have strategies to handle stress. And this could be deep breathing, meditation, and even yoga. The other issue that we need to emphasize in the management or in the prevention of asthma is the importance of adherence to treatment. So it is important to take medication as prescribed so that we prevent flare-up of symptoms. So it is important to take medication regularly and as prescribed. The other important parameter in the prevention of asthma is vaccination, because flu, we have many types of viruses that cause infections in the lungs, and they are known to trigger infections. So there's need for vaccination for these infections. And in this case, then there is need for regular checkups as well for the management of asthma. So I think we are through with our discussion about prevention of asthma. And in the recap, we need to understand the triggers. We've talked about keeping the indoor air clean. We've talked about cessation of smoke and also avoiding second-hand smoking, that is passive smoking. We need to monitor air quality, especially during times of excessive pollution. Then we need to develop an asthma action plan. This is done in conjunction with health workers. Then we need to emphasize on regular exercise to be able to help our lungs breathe better. We need to address stress, which is also a cause of our asthma, which is an important trigger. Then we need to ensure we have proper vaccination for our clients so that we're able to mitigate the effects of flu. So thank you very much for listening to me.
So thank you so much, Moyai, for that presentation. Now we will go to QA session. And let's not forget that our theme for this year is education. Asthma education empowers both to healthcare workers and to our clients. So we are going to take the questions. We'll start. Joan, I would like you to respond to a question that was asked, that if can asthmatic be subjected to spirometry? So please, Joan, you'll be able to answer that. And then another question, Joan, you will respond is, at what point do we need to nebulize a patient? Yes, Joan, maybe you can take that.
Let me answer.
Yeah.
Nebulization is done to any patient who comes with an acute asthmatic attack. So you nebulize with the bronchodilators like the Cobivent, and then you can later, if you see the patient is not responding in the first and the second, the third one you can add a steroid. You can nebulize with the budesonide, or what we call the Pamicort, as a separate. So the first thing that you do is ABC. You need to ensure that there is good air entry. So you nebulize and make sure that you give oxygen, and you can nebulize with oxygen, and then you can, and then after that you can continue. But you have to first give a bronchodilator like the Cobivent or the Atrovent, and then after that, or you combine salbutamol with an Atrovent, it becomes a Cobivent. And then once you nebulize the patient, by the time you take the third one, the patient is quite well. The other thing is that spirometry is anybody who have a patient who has a lung condition, a lung disease, apart from TB. We don't do spirometry on patients with TB until they complete the treatment and you are assured that there is no TB. But any other patient with a lung disease, and even in asthmas, how do we assess patients on asthma? One thing, you take the clinical history, then you do the clinical evaluation, either by hemogram, if the eosinophils are high. You can also do the lung function. If you don't have a spirometer, you can do a peak flow. Then you can be able to know at what level. And as you had seen the one where I was showing the loops of the spirometry, that one will help you to know whether the patient has is an obstructive or restrictive air disease. In asthmatics, mostly they are obstructive. And when you do a reversibility, where we challenge the lungs with a salbutamol, like the way we do kidneys, we challenge the kidneys with Lasix to ensure that you produce urine. We challenge our lungs so that we can see whether they are able to dilate or inflate themselves well. So we use a bronchodilator, Ventolin, and then you are able to see if there is a reversibility, then surely you know that that patient has got asthma. You may not be seeing it in the higher level, but even in the smaller airways, because there is the bigger airways and the lower airways and the smaller airways. So if you add, bigger airways are no change, the smaller airways may have a difference, and then you can be able to know that when you add the salbutamol or when you are doing bronchodilatation, dilation, the airway opens, and then you see the difference when you do the spirometry. I think I've answered the question.
Thank you so much, Joan. So in summary, Joan has told us that spirometry we can use at the point initially at the point of diagnosis when you want to rule out by challenging. And again, we can use spirometry as a follow-up when you want to assess our management or level of care in our asthmatics. So the next presenter will answer for us the the use of Ventolin. A question has been asked that since we no longer use Ventolin, what can we be using, especially in pediatrics? So I'll ask Moyai James to respond to that.
Thank you very much. Ventolin, according to the current guidelines, has been stopped, especially in adults. Why? Because it has been shown to cause dependence, especially for the steroids. And it makes the steroids not work very well over time. But for children, we still use Ventolin, and it can be used pretty well without any problem. So we are still using Ventolin in children for the control of acute attacks.
Can I add on top of what Mr. Moyai have said?
Yes, please, John, as you add, please answer the following question regarding to why was Ventolin stopped there? Why are we saying we no longer use Ventolin and we are using something else instead? So answer in that line, please.
Okay.
Yes.
According to the studies that were done in 2019, it showed that salbutamol was the main cause of the asthmatics. But in children, we are working. In children is the drug of choice that we give children, even TDS. You can give a child TDS. A veteran, you can do it TDS. You can do morning, midday, and the evening, depending on the cough that he is getting. You can do it with a spacer and a mask for children. And for adults, it was stopped because it was the main cause of the deaths. Because most of the time, the adults or all of us, we only take that one that is relieving. So we don't take care of the inflammation processes that happens in the airway. Because we saw at the pathophysiology that one of it is the inflammation. Asthma is about inflammation, and we have to reduce the inflammation processes in the lung. So that is why it was stopped from 2019. So what we are doing in the adolescents and the adults, we are doing a combination of a LAMBA and ICS. A LAMBA and ICS, a combination of long-acting beta-2 agonists with the inhaled corticosteroid. It can be a mild it can be even an Irovent, which has got a salbutamol with a beclomethasone. That one is a combined, and that one we do very well for the ones that we do in the step one management of asthma. So that is how the adolescents and the adults are doing the LAMBA ICS. So we are doing a combination. We are coming out of where we are doing one separate, where we used to have to give a patient a budesonide separate and a salbutamol separate, or where we are doing a salbutamol PRN, or when it is very necessary. Now we are doing a LAMBA ICS. It's a combined inhaler. Thank you.
Thank you so much, John. A point to note there is that we have been told that there is a LAMBA ICS, meaning steroid is a mainstay of treatment that is inhaled together with formoterol, so that we address the issue of inflammation. So another question here is why is prolonged use of corticosteroids in management of asthma prohibited, and why? Maybe this person is asking why we don't advocate for the prolonged use of corticosteroids in asthma management. So I'd like James to address that as Joan prepares to answer for us another question on at what point do you use hypertonic saline? So welcome, Dr.
The dose in the inhaler or in the formulation is extremely very, very small as opposed to the tablet formulation. It is actually in microgram form, whereas tablets have the milligrams, which is a lot of drug. So when you give it in very low doses, then it works, the side effects are few, and number two, it works locally. Just like when you have an eye drop, the eye drop will only work on the eyes. The ear drop will work on the ears, and the skin ointment will work locally. So the inhaler that we use works locally. It does not go to the system, does not go to the kidney. Very little goes there. And again, the quantity of the drug is extremely small. Therefore, you can use it for as long as possible, because as we have said, in asthma, the pathophysiology is chronic inflammation that is there for life. Even when you don't have an asthmatic attack, you still have chronic inflammation going on. So therefore, you might think you're safe, you're not having an attack, but inflammation is still going on. Therefore, when you use the inhaler, you continue to suppress that inflammation, and your lung becomes much better and much more responsive. You're able to live a quality life. Thank you.
So thank you so much, Moyai. So John, please tackle a question. At what point do you use hypertonic saline together with adrenaline use? What about, is there a time do you use adrenaline? Please, John.
Yes. When we are using adrenaline is when we are having a group. When you are using hypertonic saline is when you know that the child has got a lot of secretions. And when we are giving hypertonic saline is about 3% of saline, which is a high. It is a strong saline. So when you put saline alone, hypertonic saline, and nebulize the child with the saline, what do? Most of the child gets bronchospasms because of the salt in that hypertonic saline. So when you are nebulizing a child with hypertonic saline, can you add salbutamol to prevent bronchospasm? Because the minute you put the salt in, what happens? It will remove the secretion. But what happens? The airway constricts. So you need to make sure that as you remove the secretions, as you move the mucus or whatever you are, the secretion that the child is having, as you suck it, make sure that you have a salbutamol to ensure that the child gets an open a dilatation of the airways. The airway opens. When we are using adrenaline, we use adrenaline, especially when we have a stridor, because in children we get stridor, but you have to dilute it and then you give it as nebulization and it opens. I think I've answered.
Yes, thank you, John. Someone is asking, what's the emergency asthma management at a lower facility? So at a lower facility, please, James.
At a lower facility, especially when you have an acute attack, and probably you may not have nebulization facilities, I think you can just use the same inhaler. Then you can use it, if it is for a child, you can use the salbutamol up to 6 times. Equally for an adult, you can still use the inhaled corticosteroid that has a bronchodilator. You can repeat it 2 or 3 times. Most of the time, they get relieved.
I can also add on that. In our lower facilities where we don't have nebulization, we need to have spacers and masks. And in case we have an oxygen, like most of the facilities nowadays, they have an oxygen concentrator. You can use it to nebulize the child, to nebulize any person who really requires. But on the other hand, if you don't have a spacer, a real spacer that we are bought in the market, we can always use a bottle. And you make sure the water bottle is dry and it's cut at the bottom, and then you can use it as an inhaler. And then you put it with an inhaler. And also you can also improvise with something that looks like a mask for a baby to put it like either a cup that is a soft that you can put it like the ones that we do in a small in the neonates, that you can put it and become that you can inhale with it. And when you are doing it, especially for a child, you can do up to 10, and you can do after every 30 to 60 seconds. So once you do an inhaler, you don't put 10 of them. You don't put 10 of them. You only do 1. You shake the inhaler, you do 1, and then you breathe 10 breaths. You shake again after every 30 seconds. You put 1. You don't push. You don't push an inhaler 10 ta 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 ta. No, you put 1 puff, 10 breaths. 1 puff, 10 breaths. By the time you are reaching 5, 6, 7, already the chest has opened, both for adults and children. You don't do the 10 immediately. You just do 1 and then 10 breaths. Every 30 to 60 seconds, you can do. But before you reach even 10, by that time, the chest has gotten relief. At that time, you have released the child is able to breathe. At least you're able to increase the air saturation. At any time that you are doing a spacer on the inhaler inhalation, always put a patient on a sitting up position. On a sitting up position. It should not lie down. Even for babies, don't lie them down. Just elevate kidogo at the chest so that you can, because the objective is to make sure that there is good air entry. And what you need is just to open the airway. So when you prop the child, if it's the mother who is holding the child, let the mother hold the child at it, and they take it nicely as you are relieving. If it's an adult, don't allow the adult, even as much as he is sick, prop the patient up. Thank you.
The inhaler for the spacer, especially for the peripheral facilities or even at home, you can still use the same spacer, the same bottle. You can improvise in a way that the mouth of the bottle, you cut it almost at the neck, somewhere in between, and then you invert. You can invert the piece that you have removed and probably do some sellotape, and then it will become like the mask for the children. Sometimes it works like that.
Okay, thank you. Thank you. We have a question on is management for seasonal and genetic asthma the same or different? And then someone is asking if they can use Combiven in management of asthma. So John, you can address seasonal and genetic asthma and whether we can use Combiven, highlighting the components of Combiven. Yeah, John? John is not with us. So James, can you address whether we can use Combiven in management of asthma and what are the components of this Combiven, and then seasonal and genetic asthma?
For seasonal and familial asthma, there is really no difference in terms of the management for the two. Asthma is basically asthma, whether it is due to familial tendency or due to allergic environmental factors. And then for Combivent, you can still use Combivent in the management of, it is a bronchodilator. You can still use it in the management of asthma, especially to relieve the acute attacks.
I also, to add the top, as our doctor has said, once you do the nebulization, that is not the end of the story. That patient should go home on inhalers. And the patient, when he goes home on inhalers, he should be taught. He should not leave a facility without being taught on how to use an inhaler. And then at the same time as clinicians, because I know everyone is a clinician there, should know on how to demonstrate and to demonstrate on how to use an inhaler. And every caregiver or health worker should know the types of the inhalers that are on the market and how they are used, so that even the preference of the patients matters a lot. And also, at that particular time, what is the type of that patient? Is it a cerebral palsy child? Cerebral disability has no boundaries. Even the CPs should have asthma. How will you give that child? How will you give a CP inhaler? If it is somebody who has a disability of a kind, or the very elderly, or those that are having oxygen. So you have to always check on what the type of the inhaler that you are giving to the patient and whether he is able to use that inhaler. After you have done the first aid, after you have given the nebulization, you have opened the airway, then the long-term management, how are we going to do? And that is why we talked about, even the doctor talked about the asthma action plan. You need to have an asthma action plan. And then even when if the patient is coming now and then every day it is coming to the casualty or the emergency room. So where are we missing? Are we doing the right thing? That is when we come back and we go to the asthma control test, where we assess the patient, where we go through the patient, and that is why we have to have a good relationship, as that I said, with the patient, so that we can understand where are we coming through, where are we missing the steps. So after the rescue medicine, after what you have done, the nebulization, what next? Can we go home on an inhalers? What type of an inhalers? Are they viable? Is that patient able to use? Does he have a kind of a challenge? What can we do? Has he gotten a stroke? What should he be given? Those are the things that you need to know, even when you are seeing the patients at the clinical area. Thank you.
Thank you so much. Another question here is, are there specific steps in management of asthma? And we are saying yes, there is stepwise management of asthma from step 1 to step 5, according to the severity of asthma. And there is difference in management in terms of drug combinations and dosages, where you'll start from low dose ICS LABA to high dose ICS LABA, and there are add-ons that will be added at every steps. So that one is a whole presentation we can organize so that we do that presentation. It will need time so that we do it well. For today, we wanted to really talk on asthma education as an empowerment to healthcare workers and our clients. So having that much, we would like to have parting shots from our presenters. We'll start with James Moyai, and then we go to Joan to give us their parting shots on asthma education and empowerment.
Thank you very much. I'm really excited for this talk. And I know many people have a lot of answers, questions that we need to answer later. But generally, we want to say that asthma is a condition that we can easily handle. It is a condition that is easy to handle. However, mortality can also be an issue with asthma, especially if you don't control the symptoms. So it can sometimes be fatal, and sometimes it can be very easy to manage once you know how to, especially use your inhaler very well. If you're using your inhaler incorrectly, then you'd rather not use that inhaler at all, because you're wasting the drug and will have catastrophic expenses on you, and you will not be able to function optimally. So therefore, the key thing here is that we need to know how to teach our clients how to use inhalers properly, to adhere to treatment, and to be comfortable with the condition, because we still have stigma within us. And even the patients, when they come to us, most of our patients, they deny. They say, no, I don't have asthma, and I will not use this medication. So we still need to have a lot of health education to our people so that they are able to accept the disease, to use medication correctly, and to be able to function well. Thank you very much.
Thank you, Dr. Now we'll have sentiments or closing remarks from Joan regarding this presentation. And please, Joan, mention something on tomorrow's event on World Asthma Day, so that for our staff or they can attend the function in our hospital. Welcome, Joan.
Oh, thank you, Gladys. I appreciate, and thank you for the whole team that have been there. Thank you for all the partners and the participants. And my parting shot is that understand asthma. Asthma you can get whether you are old, whether you are young, whether you are in the middle, because most of the time, especially my colleagues, I cannot have asthma. And you can get whether you are at work or not. The other thing is about stigma, as Daktari has talked about. The other thing is about inhalers. Everybody talks about being addictive to inhalers. There is no addiction in inhalers. You have to control your asthma through the use of inhalers. There are various types of inhalers, different types, very nice and good ones. And despite the cost, we have to continue taking care of ourselves. And for me, I talk about breathing. I have to make sure everybody breathes. So when you take an inhaler, I'm assured that you are going to be able to breathe and you are going to be able to live a normal life. Even in children, even where parents just refuse to understand that a child can get asthma, they are there. But with the medication, with the inhalers, because we don't take orals, and also avoid syrups. Avoid syrups. Most of the times in the facilities, you find that you are giving syrups. Please, in pediatrics, no syrups. In pediatrics, no syrups. So we should not give syrups. Let's do inhaler. Let's do inhaler with a spacer, with a mask for everyone. And then for tomorrow, we are having an asthma. We are having World Asthma Day. We shall be celebrating at Kenyatta National Hospital. Next to the National Bank. There will be a lot of things happening there, and you are most welcome. You'll be screening. So anyone who feels that he has an issue or he has a friend who has an issue, they can come and we shall do a free screening. And I appreciate it. Thank you. Thank you. Thank you, team.
Thank you so much, John. At this juncture, I would like to thank everyone who has participated in this very informative session. Stay tuned for our upcoming webinars, especially for the respiratory disease unit here at our KNH. We will look into a day that will have more detailed presentation on asthma, because we've seen many questions need a whole wrap up of everything. Thank you so much for being with us, everyone. Thank you, our presenters, and have a good evening. Thank you.
Thank you. Thank you.
Thank you very much.